I want to welcome everybody to the program today. This is the Impact Education series that they put on called Payer Talk. It's a CE program, and we're going to be focusing on understanding type 2 inflammation, and we're going to spotlight atopic dermatitis. So this PayerTalkCE program is jointly provided by Partners for Advancing Clinical Education and Impact Education. The activity is supported today by an independent educational grant from Regeneron and Sanofi, and so we'd really like to thank them for their support to make this program available. I'm Dana McCormick. I am a senior director with Optum Insight, which is a consulting division with Optum. We focus on working with managed care organizations on pharmacy strategy. So at the conclusion of the program today, you will be asked to complete an evaluation, which you'll need to submit in order to receive the credit. You'll just click on the complete evaluation, will pop up in the navigation. And once you complete your evaluation, you can click on claim credit to download your certificate, or for pharmacists, your credit will be submitted to the CPE monitor. I am super excited today to be joined by Dr. Sean Quatra. He is an internationally renowned dermatologist and a clinical leader in skin of color research. He also focuses on chronic inflammatory skin diseases and does a lot of work in the area of atopic dermatitis. He's currently with the Joseph W. Burnett Endowed Professor and Chair in Dermatology at the University of Maryland School of Medicine. And I just want to welcome you, Dr. Quatra. And would you just give us an introduction and tell us a little bit about your background?
Thank you so much for having me here today. Really excited to be talking more about type 2 inflammation today. So a little bit about me. I treat atopic dermatitis patients and have a specialty clinic where I treat them. I also do clinical trials and also research, both bench research with mice and translational research with humans as well. So I like to think that we're at every end of the spectrum, from seeing patients at the bedside to helping to come up with new mechanisms and therapies and bringing that back to patients. So we're really excited to talk about atopic dermatitis, the role of type 2 inflammation, and also the emerging revolution that's going on right now with new therapeutics.
Thanks, Dr. Quatra. Appreciate your introduction, and thanks again for joining us today. The learning objectives for today's discussion is describing how type 2 inflammation plays a central role in atopic dermatitis. And then we're going to talk about the safety and efficacy of evolving treatments for patients who are suffering with atopic dermatitis. So let's just jump in here. Can you talk a little bit about type 2 inflammation and how it contributes to the pathophysiology of atopic dermatitis? And then a little bit, if you want to dive in a little bit into the key cellular and molecular mechanisms involved in the inflammatory process behind the scenes.
Yeah, absolutely. So I like to start very broadly when I talk about type 2 inflammation. And type 2 inflammation can be thought of as your body's immune system overreacting to something it sees as a threat. Often this could traditionally be in response to allergens like pollen or dust. But instead of just dealing with the threat, your immune system would then kick into overdrive, sending out a bunch of signals and messengers that lead to inflammation. This can cause problems like atopic dermatitis, but also asthma and allergies. So the way we like to think about atopic dermatitis and type 2 inflammation is there's a fire alarm that goes off even when there isn't a fire. Your body gets very worked up, leading to symptoms like uncontrollable itching and rashes, wheezing and asthma. So that's why I like to think about the historical context for why type 2 inflammation is important, because it was a form of response to external environmental triggers, parasites, all things like that. So more molecularly, the type of immune response is characterized by overreaction of certain cytokines, such as IL-4, IL-5, and also IL-13. And so that's why it's associated with many of these allergic conditions. In this type 2 inflammation, there are certain immune cells that are more heavily expressed, like eosinophils, mast cells, what we call Th2 or T helper 2 cells. And these cytokines can lead to a lot of the symptoms that we see with atopic dermatitis. So type 2 inflammation is important for a lot of reasons. It helps us understand a lot of these allergies and underlying pathophysiology, but also because it's been an axis of new treatments as well. So that's really the most exciting aspect of it.
Has there been any recent research looking specifically at the different cytokines and any one cytokine playing a larger role or different responses to medications based on the different cytokine response?
Oh yeah, it's a really great question. And so what we do know is that several cytokines. So I'll go through a few of them in more depth. The first one is IL-4. So IL-4 is really important in terms of starting the cascade of type 2 inflammation. So IL-4 plays a very crucial role in converting your body's inflammatory cells or naive T cells into type 2 cells, which are involved in this allergic response, also the defense against parasites. IL-4 also stimulates B cells to produce the immunoglobulin E or IgE, which is important for allergic reactions and helps in the immune response to parasites. Eosinophil recruitment, so IL-4 promotes the growth and activation of eosinophils, a white blood cell that's important in allergic inflammation. It also leads to tissue remodeling and a lot of the rashes that we see. So that's why IL-4 is, really up there because it's very upstream as well. The next important cytokine is IL-13. So IL-13 is very closely related to IL-4 and plays a role also in the type 2 response. IL-13 can also promote IgE production, eosinophil activity, as well. And it's really a crucial regulator of inflammation. So those are two of the most important cytokines. I think there are some upstream cytokines, so right near the skin barrier. They're called alarmins. So these cytokines, they have names IL-25, IL-33, or thymic stromal lymphoprotein, or TSLP. And all of these are very close to the epidermal barrier, activated with antigens, and are thought to, increase the type 2 inflammatory response. The reason I highlight IL-4 and 13 is because one of the most crucial symptoms in atopic dermatitis is neuroinflammation. So that process that leads to itch and rash. And the receptors for IL-4 and IL-13 are actually in your skin, on a lot of these immune cells, but they're also on nerves that travel all the way through the spinal cord and the dorsal root ganglion. And they're very much so involved in itch signaling. And itch is just a huge part of atopic dermatitis. I mean, it's the hallmark symptom. So you really can't have the disease, without having itch. And so that's why I like to highlight those different cytokines. What we have found, though, is that targeting upstream targeting cytokines that are near the epidermal barrier, like IL-33 and IL-25, the so-called alarmins don't work as well, but targeting IL-4, IL-13, that's really the key nexus of type 2 inflammation. And we know in 2017, there was a breakthrough with the approval of dupilumab, the IL-4 receptor alpha inhibitor, that I believe has led to a near total translational revolution for the management of many of these type 2 inflammatory diseases. And we've seen, atopic dermatitis, allergic rhinitis, asthma, many diseases that are focused on that IL-4 receptor alpha because it's able to block IL-4 and IL-13 signaling, and so stops the type 2 inflammation in those type 2 cells from actually forming in the first place, stops these inflammatory cytokines. Now we're seeing specific cytokines also targeting IL-13 that are emerging, et cetera. So it's been just very exciting developments in this space the last few years. I can't tell you how exciting it is for all of us, docs and providers taking care of patients too. It's just really special.
Do you think that there's a good understanding within the clinician community around the involvement and the differentiation of type 2 inflammation as it relates to atopic dermatitis?
So I think that's a great question. Understanding the differentiation of type 2 inflammation with atopic dermatitis, I think, has been, to be honest, largely influenced by the success at the bedside with dupilumab therapy. I can't state this enough because us clinicians have been taking care of these atopic dermatitis for many years. And prior to 2017, this was a very challenging patient population to take care of. So we would have to use off-label and systemic immunosuppressive agents like cyclosporin, methotrexate, mycophenolate, mofetil. Those are all, some of the agents that we had to use. And with the introduction of dupilumab, we've seen very targeted therapy leading to excellent clinical responses. So I think that finding at the bedside of therapeutics working has in many ways almost redefined the pathophysiology of atopic dermatitis. We know that there's many important mediators in atopic dermatitis. The genetics are very important. Atopic diseases tends to run in families. I have both atopic dermatitis and hives or urticaria. So that runs in families. We also know that this filaggrin gene deficiency and other genetic deficiencies can lead to impaired skin barrier. So, that can be featured by dry skin and actually like increased transepidermal water loss. And so that's like an important thing to consider. But we also know that it's because there is this barrier dysfunction, there's involvement and close proximity to the outside environment. So microbes, allergens that are all able to stimulate the nerves and the immune system to get fired up. So it's the environmental factors, pollutants, also is exposure to cigarette smoke, the environment that you're in, your genetics, and then your immune system. But what we're finding is that the immune system and targeting type 2 inflammation is able to reverse and improve the skin barrier. It's able to reverse and improve a dysregulated skin microbiome. So say if you have Staphylococcus aureus colonization, it can reverse that. And then it can rapidly reduce symptoms of neuroinflammation like itching. So in many ways, what we're searching for is the therapy that's actually one of the master conductors in this cycle of inflammation and rash. And we're finding that type 2 inflammation is actually able to target it. So I do think there's been explosive growth among clinicians in our understanding, but I think it's directly tied to what we're seeing with treatment. And I'll tell you, everyone has been blown away, including myself, how you can target one receptor so specifically, or one target like IL-13, IL-4 receptor, this whole target complex, and be able to have just dramatic breakthroughs. And so that's been one of the most important breakthroughs, I think, that has helped to reorganize our understanding of pathophysiology of type 2 inflammation, atopic dermatitis.
Thanks so much, Dr. Quatra. So, given what we do know and about how much we've learned around type 2 inflammation, what are the clinical implications in atopic dermatitis regarding symptom presentation and patient quality of life?
Yeah, it's a great question. So, what I would say is that type 2 inflammation is directly tied to many of the symptoms that our patients experience in quality of life. For example, the hallmark symptom in atopic dermatitis is pruritus or itching. And type 2 inflammation leads to intense itching. We know that IL-4 receptor, IL-13 is important. This can disrupt sleep and daily activities as well. With regards to eczematous lesions, type 2 inflammations can contribute to the inflammation of allergic immune cells like eosinophils that contribute to the characteristic red and inflamed skin. Flare patterns. So many patients experience flares triggered by allergens, irritants that also help to trigger type 2 inflammation, exacerbate type 2 inflammation. And then also secondary infections. So many of these patients suffer from intense itching and rash flares that are due to a compromised skin barrier, excessive type 2 inflammation, and also increased susceptibility to bacterial and viral infections, such as Staphylococcus aureus, which can also impact those symptoms. So I do think that there's a lot of correlation. And we know that many of these patients have sleep disturbances, nighttime itching, anxiety through the sleep, which is all tied back to the itching as well. Many patients have embarrassment going outside because of the lesions, which are all tied to type 2 inflammation. So I think that this is particularly a situation where all of the symptoms, pruritus, eczematous lesions, skin barrier dysfunction, psychosocial impact, sleep disturbances, all of these things can tie you back to some discrete element of type 2 inflammation. So it really is neuroimmune targeting. The itch, sleep, can exacerbate eczematous lesions. The inflammatory involvement of the immune cells, which can cause those eczematous lesions, lead to psychosocial impact. So I really think the key of type 2 inflammation is that it targets inflammation and itch. And being able to hit both reduces the appearance and presence of lesions and the symptoms that are causing a lot of the bad things about what the patients are experiencing. So truly, you're able to hit it, the patient's symptoms. And many of the studies, including our lab studies, have looked at patient symptoms like itch related to type 2 inflammatory biomarkers, and they're very closely, neatly associated. So we know there is a pathogenic role there.
So I want to kind of try to put a patient in mind. Is there or is there not a typical patient presentation that by the time a patient gets to you, is there a typical presentation?
Well, for me, I see a lot of patients that have pretty severe disease. So oftentimes patients will have been given a diagnosis of eczema when they're younger. It's had a waxing and waning course. They're in a severe flare. They've seen a primary care doctor and been given topical steroids like triamcinolone. And this is really inappropriately and not completely managed the patient. They're still having significant itch. They're still having quality of life disruption. And then they come in, incompletely treated. And I see patients who have been on topical steroids for years and also have side effects of topical steroid therapy. They have skin thinning, hypopigmentation, atrophy, telangiectasias in blood vessels, a lot of that stuff. And they're really dejected also. I think that there's a big problem going around that there's a major delay in appropriate systemic therapy. So one thing I always ask patients is, what is your itch right now? Like 0 to 10. Like where do you sit? Where do you live? What's been your worst itch in the last 24 hours? And that's been very helpful, I'd say, because if patients like above a 7 or so, that's very severe. And to me, independent of what the rash looks like, I will start systemic therapy usually in that scenario. And I think we need more objective questions to be able to initiate systemic therapy. We need to ask patients because if they're itching, they're not sleeping, they have probably some elements of anxiety, depression, other psychosocial distress. So we need to be very mindful of this when we're treating patients. I think the biggest thing I'm seeing is undertreatment of patients. That's really one of the most common features of what I'm seeing.
How does type 2 inflammation influence the long-term outcomes for patients, and what should clinicians be thinking about in helping to manage and prevent the long-term complications?
So type 2 inflammation is certainly associated with some long-term outcomes of atopic dermatitis. First off, chronicity. So type 2 inflammation is very much so tied to the chronicity of atopic dermatitis and other allergic diseases. So persistent inflammation can lead to more long-term changes, such as lichenification, skin thickening, secondary prurigo nodule formation. Also, decreases barrier for other things like sustained airway hyperreactivity and asthma. We know that the longer a rash is treated, the more hardened it can get to therapy. So it's very important that we treat these rashes very aggressively up front. Type 2 inflammation can also lead to increased severity of symptoms if you have chronic type 2 inflammation. You can have more significant impairment in quality of life over time. Imagine someone's itching overnight and not sleeping well. Well, their anxiety, their depression, other types of things are only going to get that much worse. I would also say that there's a risk of comorbidities that are associated with type 2 inflammation. Patients with type 2 inflammation are at a higher risk for several disease comorbidities. We know traditionally there's asthma, allergic rhinitis, and food allergies, but now there's been more research also suggesting there may be a link with cardiovascular disease and other systemic problems with chronic unchecked inflammation. Our lab's also shown that several biomarkers of systemic inflammation, like C-reactive protein or erythrocyte sedimentation rate, are also increased in the bloodstream of patients who have itching at night, which is many of these atopic dermatitis patients. And then I would also say the skin barrier, persistent type of inflammation can lead to ongoing skin barrier dysfunction, making you more susceptible to infections and irritants. We talked about psychosocial impact as well. So this is why type 2 inflammation can actually be very much so tied to disease comorbidities. And specifically, type 2 inflammation is part of a broader allergic phenotypes. And what I would say, this has paramount significance in children. So if children present with severe atopic dermatitis, they are at great risk of having other atopic conditions, asthma, allergic rhinitis, food allergies. Even this last week at the European Academy of Dermatology and Venereology meeting, we saw a presentation, an abstract about how early treatment with a type 2 inflammatory therapy, dupilumab, can actually cause and help patients who are low height to actually catch up in their growth. So there's actually possibly a relationship to bone growth, bone health, asthma, allergic rhinitis, food allergies. It's really important not to leave this persistent inflammatory disease state. If you don't treat it early, you're more likely to have a chronic disease course and more severe atopic dermatitis phenotypes, prolonged disease flares, and it'll necessitate more aggressive treatment strategies later on as well. So just a whole host of things that are brought in.
So, what are the current strategies for managing type 2 inflammation in atopic dermatitis, and how do they target specific inflammatory pathways?
Yeah, so there are several therapies. So first off, let's just talk about the most common. There's topical corticosteroids. These are inflammatory agents that are nonspecific. So they target really all immune axes, including type 2 inflammation. They reduce cytokine production of implicated cytokines like IL-4 and IL-13, inhibit immune cell activity. And typically this is given off the bat to many patients. And they're okay for short bursts of time, but again, we worry about the lack of specificity and the side effects, skin thinning, atrophy, telangiectasias. Those are all considerations. When many of these patients visit with their primary care providers, they also oftentimes are given oral corticosteroids, which I'm very much so against. The oral corticosteroids, such as prednisone, can provide rapid anti-inflammatory effects. But again, they suppress type 2 inflammation, but also type 1 inflammation, type 17, type 22. They're very nonspecific, and they actually totally suppress the immune system. So, of course, people's itch and their rashes get better. And, this can be given during severe flare-ups. But the problem is it's not a long-term therapy. You'll get bone thinning. You can have insomnia, weight gain, all those different terrible side effects. And also, you can also have flares when you get off. So if you taper down your prednisone, then you're more likely to flare. So really just an inappropriate therapy that's still given a lot. I tell you what, I see patients all the time that are inappropriately managed on oral steroids and referred to us, and it just shouldn't be happening. Other therapies that are used, so there's topical calcineurin inhibitors, for example, tacrolimus or pimecrolimus. These are also nonspecific therapies, similar to topical steroids. They inhibit T cell activation and cytokine release, but again, across immune axes, not just type 2 inflammation, type 1, 17, 22. The benefit is that they don't have skin thinning associated with them, so it's effective for sensitive areas like the face and eyelids, especially for long-term management. It's okay. So that is also something to consider. And then in terms of other therapies, we know that there are biologic therapies. So, for example, IL-4 and 13 inhibitors that are at the core of type 2 inflammation. We know that dupilumab was first approved in 2017, and it targets the shared receptor, IL-4 receptor alpha 4, IL-4 and IL-13. So able to block neuroinflammation that way, and effective for patients with moderate to severe atopic dermatitis. We know there's other agents as well, tralokinumab, an IL-13 inhibitor, and also more recently, just a couple weeks ago, a new agent, lebrikizumab, which is more potent towards IL-13 inhibition also. And so those are our three biologics that are approved that are now targeting this IL-4 and 13 nexus. So those are the most important biologics. There are classes of JAK inhibitors. So there's JAK inhibitors like abrocitinib, upadacitinib. These are thought to be more selective JAK1 inhibitors, and they target type 2 inflammation, but also have some activity in other immune axes, which can sometimes be helpful for different endotypes of atopic dermatitis. There's also topical ruxolitinib, which is a topical JAK1 and 2 inhibitor that actually works within minutes of application. So in the phase 2 study, it actually was more effective than triamcinolone, a steroid, on itch and inflammation without the skin thinning side effects. So all of these have been just tremendous additions. They're all safer than non-specific immunosuppressants, in my opinion, that we'd had for so many years, like cyclosporin. I mean, we shouldn't be using cyclosporin, methotrexate, mycophenolate anymore, but we're still seeing it a lot. So it's kind of a little bit of a mismatch that I think education is helping a lot, but we still do have, some areas there that we need to address. There's also other therapeutics like phototherapy that are good adjunctive combination therapies. And I'll also mention there's a new novel topical therapy that was just approved, also topical roflumilast, which is a very potent phosphodiesterase 4 inhibitor in addition to crisaborole. So I think there is a role for combination therapy where folks are getting a systemic therapy, also topical therapies, many of our novel topical therapies.
So, recognizing that by the time a patient gets to you, Dr. Quatra, they usually have more severe disease. Can you talk a little bit about how you would, how you evaluate a patient and make decisions about what your therapy approach will be?
Yeah, it's a great question. So, what I would say is you want to have a severity assessment of patients, and there's different ways of doing this. I like to ask everybody about their itch score, 0 to 10. What's the worst itch you've had in the last 24 hours? I think that's a great barometer overall of where you're living and can be helpful, even if there aren't extensive skin signs. There's also simple things like the Investigator Global Assessment Score or an EASY score, which now we actually need more for payer coverage as well. So those are simple things to ask for. And then after that baseline assessment, you can then go ahead with therapy. I would say if it's very limited disease in terms of body surface area, just a few percentage, then you can go ahead with topical therapies. But many patients will probably need to progress quickly to a systemic therapy. That's been one of the biggest gaps in my view, is that we haven't pushed patients towards systemics or offered it for shared decision making early enough. We just relied on topical steroids. In my view, you want to treat to clearance. You want to get patients totally clear. That's one of the big things that we want to take care of in these patients.
Dr. Quatra, can you tell me a little bit about when you're talking with a patient, what are some of the components of that shared decision making that you and the patient are talking about to help drive therapy choices?
Well, I'm asking them, are you sleeping? I'm asking them about their itch, as I mentioned, and I'm asking them, how important is the timeline here for how quickly we get you better? I don't like to make judgments that, oh, you have to try this and then we go there. I try to have a conversation and assess, do they really need to get this better fast? How are they struggling? And you can get a sense very quickly, I think, just with a few questions. In general, people are itching a lot. They're not sleeping well. I'll try to discuss with them and guide them to a therapy that clears them. My personal approach is to be a little bit more aggressive to get people to stop suffering immediately. And then, we can find a nice maintenance or other method to get them clear. Again, with safe therapies, that's the main thing I'm trying to convey to people is that now we have therapies that have extensive clinical trials data, and we can feel very comfortable with these therapies. And so I want people to really understand. And now having so many therapies, that it actually puts more pressure on us, the providers, to be able to explain it in a very coherent way also.
So once you've started a patient on therapy, how do you measure success, positive therapeutic outcome to then make a decision to step up therapy or to change therapies?
So I'll usually give the therapy some time to work, see them back within a few months. And we want to first think about symptom control. So what is their itch score in the last 24 hours or 7 days? What's the worst itch they've had in the last 24 hours? I'll write it down in the last note. I can compare it. If it's a 10 before, what is it now? 4 or 3? Are we heading in the right direction? If it's staying at 10, then, I got to think about that, what we're doing. We'll look at the skin. So we'll see, does the rash look better? I oftentimes take photos for the medical chart. I'll do an investigator global assessment or EASY score, which we have helpful tools online for. Those are some simple things to ask. And then I'll ask questions about sleep quality. I'll ask patients about quality of life, anxiety, like briefly, some of these things if there's time permitting. But those are the biggest things. So what you're seeing on the skin, and then their symptoms, itching and how they're sleeping. Those are really the biggest things. But you normally got to give it a little bit of time to work, a few months, 3 or 4 months. I usually give patients a little bit of time to see just how it works and what's their depth of improvement. Many patients continue to improve after that time period. So if it's been a few months and they're getting better, we'll oftentimes stick with therapy only if they really have a suboptimal response. Say their itch score doesn't get better, they're still not sleeping well, they're still itching, maybe we need to bring them in sooner and then perhaps do something else more aggressive. But it's really monitoring the itch and the inflammation, those two things very closely.
Does adherence ever play into therapy choices? And do patients typically have adherence issues to therapies that you work with?
Yeah, I think it's helpful to simplify. So that's one thing I've learned is it's difficult if someone gives you, I'm guilty of this, giving patients like multiple different things to do at the same time. So I try to clarify, synthesize, simplify. Okay, I want you to do this ointment or moisturize this way once or twice a day. We'll start this systemic therapy, see you back in this number of months, write it out for them. So that's one thing I've learned that I think it increases in adherence to simplify things for patients. But absolutely, I mean, there's a lot of fear about about the topical prescription use. And so I try to educate about safety and say, this is okay to use at this interval. There's good studies, and I think that helps adherence too. But I mean, certainly that's always a consideration, adherence. Even myself, I'm very not adherent many times as well. I have eczema and I'm very not adherent. So I know that that's the case.
How do you feel? You've talked a little bit about EASI and IGA scores. And I know that those are typically outcome measures related to clinical trials to, show outcome of drugs when they're being, evaluated for use in atopic dermatitis. How common is the use of those types of scales used in practice versus kind of how they're being evaluated in the clinical trials?
Yeah, it's a good question. I think that most people don't use them traditionally, but one thing that's happened is that to get payer coverage for many of these therapeutics, you kind of need to document them. So I think that started to happen more frequently that people are documenting these things. I think the investigator global assessment is pretty straightforward because it's like you're clear, almost clear, mild, moderate, severe, very severe. Like that's pretty basic. The easy score, there are some calculators online. It's a little bit cumbersome, but basically you measure the percentage of body surface area affected, like the head, trunk, the limbs, and then you assess for clinical signs, erythema, edema, excoriation, lichenification, and then kind of add that up to get a score from 0 to 72. So doing it more because of payer coverage. There's so many tools for atopic dermatitis. There's like the atopic dermatitis control test, which is also good. But to be honest, in a busy clinic, it's very hard to do a lot of these tests. And it's been very difficult for providers because there have been Medicare cuts and there's a lot of pressure to see a good number of patients. And so I think that the pressure is really on providers. For me, I try to get an itch score in everyone and at least an IGA, which is 0 to 5, and the itch score, I mean, it scores 0 to 10, and those take just a few seconds. And then now we're having to do a little bit more easy scores. But other than that, it's just, I feel like we're asking too much of docs to do all these questionnaires and other things. And so my heart goes out because, I feel it when I'm in clinic, and I know other people are feeling that burden also. But I think if you can do just a couple easy, straightforward things, it'll help you just to have an objective way to check how your patient's doing when they return and to help you advocate for them to get on systemic therapy.
So, can you talk a little bit about clinical guidelines in atopic dermatitis?
Sure. So, clinical guidelines in atopic dermatitis are great frameworks for care. So recently there was a American Academy of Dermatology guideline that updated the 2014 guidelines. And in that, there were really strong recommendations for the use of dupilumab, also other monoclonal antibodies like tralokinumab, also JAK inhibitors, abrocitinib, upadacitinib. Now there's obviously approval of lebrikizumab too, but they also made some conditional recommendations for phototherapy and other nonspecific immune suppressants like azathioprine, cyclosporin, methotrexate, but really against the use of corticosteroids. So that's pretty interesting that there was consensus there about conditionally recommending against the use of systemic steroids. So that's, I think, really helpful for patients. For phototherapy, adjunctive therapy, there's recommendations for narrowband UVB because that limits some of the side effects. But again, I think these biologics therapies and also JAK inhibitor therapies who have FDA approval were in there. So I know the biologics were in there, but for the JAK inhibitors, they also noted that as for patients with AD who have failed other systemic therapies, so pills or injections, including biologics, or when other therapies are not recommended. Non-specific immunosuppressants like methotrexate, they may exacerbate certain toxicities. There's a lot more lab monitoring. So I think that helped to clarify where the field stands for a lot of these new therapeutics.
So in the guidelines, I know one of the things that, the defining the disease state in terms of mild, moderate, severe, using those kinds of words, is there any kind of guidelines that address how to characterize disease based on its severity?
Yeah, so I think we're still evolving with what is mild, moderate, and severe atopic dermatitis. Obviously, it's still like a shifting target. And I think with new therapeutics, we're lowering the bar as well for initiating systemic therapy. So we're still working on that. I think that there's different things like the SCORAD that talks about mild disease. And then there's moderate and severe. And there's all these bands within the easy score, within an itch score, 0 to 3, 4 to 6, 7 to 10. But I think there's still some work being done about what is more mild to moderate severe disease and what is more severe disease. To me, it doesn't matter what's on your skin. If your itch score is very high, then you're more moderate to severe. So I think this is something that we're still trying to work out. I think truly, if you have localized, say less than 2 to 3% involvement, you can qualify that as mild. But there's a lot of different factors that go in. It's very hard to say a strict, body surface area cutoff and all of that.
No, that's great. So you mentioned about two more recent approvals earlier. Could you talk a little bit about some of the emerging therapies and what excites you the most about the upcoming discoveries as it relates to medications to treat atopic dermatitis?
Sure. So we just had the FDA approval of lebrikizumab that targets IL-13. There are other agents that are also in development, like nemolizumab, a drug that targets IL-31 for atopic dermatitis, one of the itch cytokines. There's other classes of medicines, such as OX40 inhibitors like amlitelimab or rocatinlimab that target elements of OX40, which are associated with memory T cells. So the hope is there will be longer times off therapy as well for patients. Those are really the most exciting things. I think there's also that topical phosphodiesterase 4 inhibitor, roflumilast, that's now been approved. That's very potent, safe, and another great non-steroidal options. I'm really a big fan of these non-steroidal options.
Dr. Quatcher, could you talk a little bit about the difficulty in assessing and diagnosing and managing outcomes for people who have darker skin colors?
Yeah, absolutely. So in darker skin tones, one of the interesting aspects that we see is that it's very difficult to evaluate the erythema or redness. And in many clinical trials, the metric that we use is the EASY score or the SCORAD, which these scales can take into account erythema or redness. So that can be certainly a difficult thing that you're not able to appropriately assess redness when this is one of the criterion that we use to assess disease severity. So what actually has been seen is that sometimes skin of color patients and patients with darker skin tones are not able to get on systemic therapy as early as they may be warranted to because of, systemic underassessment of their disease severity. So there's things you can do to check those disparities. For example, you can always ask patients, how bad is your worst itch, 0 to 10? Make them give you a number. And then if there's a mismatch between what you're seeing, you can, up titrate your therapy accordingly. There's also education about the appearance of atopic dermatitis in darker skin tones patients, how you oftentimes can see violaceous rashes, so purple colored eruptions. You can see, less erythema and more excoriations and papules that are hyperpigmented. So understanding you can have hyper or hypopigmentation, so darkening or lightening, and more of a purple color can help. It can be very subtle seeing folks who have that erythema. So these are all important things to consider. But I do think that asking about itch is a way to eliminate some of those barriers from your own eyes, being able to see an eruption, accurately assess and initiate the appropriate therapy. So great question. And I also think that the disease presents differently in patients who have darker skin types. So you can oftentimes have more papular disease, so small bumps instead of just flat red areas. It can also affect different areas. So traditional atopic dermatitis affects the antecubital fossa and the elbows behind the knees, but in darker skin patients, oftentimes it can assess the outer portion of the knees, the outer portion of the arms, the hands. It can affect these extensor areas. It can have more papular formation, skin thickening, secondary skin thickening, lichenification, all of those things. So that's really important to understand that the disease can present differently, especially in children. I've seen so many children that have been underdiagnosed because they haven't recognized that there can be more follicularly based bumps. So many of these patients can present with small bumps on their body. But I think we're getting better in terms of recognizing the different disease phenotypes, being able to appropriately initiate therapy. I do think we're doing a little bit better of a job.
Thank you so much, Dr. Quatra. I think I'll end the session. Again, I can't say thanks enough for your insights and helping bring to light all of the important factors of type 2 inflammation and the role that biologics play in the treatment of atopic dermatitis. So thank you very much. Appreciate it. I also want to thank Impact Education and Regeneron and Sanofi for helping make this session possible. And just a reminder to everybody that if you're going to claim credit, you'll need to fill out in the evaluation form. And then again, really appreciate you taking the time to fill those out. And thanks so much for joining us.